From Diamond Pharmacy Services, this is PodcastRx, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. Pharmacist Henry So from Diamond's Optics clinical team makes his first repeat visit to the show for a discussion of monkeypox, its origins, symptoms, transmission, and even the reason behind its unusual name. We also talk about the available vaccines and antiviral treatment options, and what Optics is doing to help educate correctional healthcare partners about monkeypox. This is PodcastRx. I'm Adam Campbell. Henry, it's great to have you back on the show again. I wanted to know, since our last discussion, how's the world of optics been treating you?
Oh man, it's a pleasure to be back, Adam. Really appreciate the invite. World of Optics has been great. The amount of growth and collaboration has been astonishing within the team. So really happy with everything that's been going on. But what about you? How's the world of marketing been for you?
Oh, very busy down here. My colleagues and I have very full plates heading into the fall, but it's been going great, and we've been having a great time. Speaking of timely, fast-moving things, I wanted to get you on the show to talk about monkeypox. That's a very top-of-mind topic right now, just in the news and in healthcare, and of course, it's also, as I already said, it's very fast-moving. So, to get you on here sooner rather than later to talk about it is best. And I know that in your everyday optics work, you recently drafted a primer on monkeypox for our partners. And I figured having you on the show that would be a good supplementary resource to that printed piece.
Yeah, definitely. We did a primer and then we did a bit of a guidance document. But yeah, that was a great catch. We really do want to try to disseminate this information as best as possible. To be honest, it's been tough keeping up with everything that's been going on, with COVID and all the complications with that. So we are very glad to be able to provide this for our health partners. We just, I'm going to say it again here and there, but sometimes it's just hard to imagine some of our providers and health partners sitting down, really looking at that computer, opening up a bunch of tabs and trying to really centralize the point of what the CDC and the FDA and other governing health bodies are trying to say. So yeah, it's a good catch. We definitely want to try and put this out there as best as we can.
Yeah, absolutely. And, before we get into the main discussion, it's worth saying, we've all grown weary of this pandemic life over the last few years. Just when we think we turn a corner away from the sort of doom and gloom pronouncements about outbreaks and everything that comes with that, and we're learning to live with COVID-19, then you see alarming headlines about a new public health emergency with, let's face it, a beastly name that calls to mind, at least for me anyway here, the pop culture trope of a monkey spreading an infectious disease from an exotic place. I'm thinking particularly about Outbreak. That's a 1995 film starring Dustin Hoffman. Showing my age a little bit here, but by no means is it just limited to that. I mean, we've often heard about monkeys spreading disease, and that's where my mind is immediately gone to that when I've heard about monkeypox. But obviously, it is not what's portrayed in that movie, and we're going to get into that. But either way, it's a very interesting time for another disease outbreak to happen, given what we've gone through for the last couple of years.
Yeah. I mean, so I'm going to show my age a little bit. That movie came out when I was 3. I'm not too familiar with the content, but I know it has something to do with monkeys. But I think, this is a really good thing for us to do in terms of, I guess, kind of clearing the air about what's going on with monkeypox, and I'm sure we'll dive into kind of the origination of the name. But yeah, it's the new norm is kind of transforming. It seems as though every year we're kind of grappling with a new public health emergency, or just the remnants of a previous one, and it's kind of really just turning to something where we're trying to mitigate the risk and contain the spread as best as possible. Typically, how we've been encountering these public health emergencies or infectious diseases is story here. and now we need to deal with it and kind of suppress those cases as best we can. Yeah, the good thing is really in terms of, the doom and gloom and trying to sift through all these different articles is, our optics team, we actually all do our own little readings. We have our trusted sources from different medical news, world news. So we really do talk about a lot of these new emerging infectious diseases that we want to prepare information for our health partners for. But it is difficult to navigate a lot of the less concerning viruses we see pop up. You've seen sometimes turtle flu or different names that just sound very creative and very anecdotal in terms of where it's come from and where it's been seen. We're even hearing things about Langia virus from China. But overall, we do sit through these and try to minimize the drama and minimize the sensationalist headlines and really try to discuss and kind of see the impact that it has on our patient population. And this is how we as a group are able to put out definitive guidance for monkeypox awareness in early July. We were discussing this probably early June when we first started seeing some early cases. And, we discussed it week after week after week. And finally, early July, we decided to put something out that was digestible, centralized, and just another piece of ammunition for our health partners to be successful in their practice.
Yeah, absolutely. And along with this podcast, you'll probably be putting out updated guidance as, more information becomes clear. This is, of course, a very fast developing situation with monkeypox. But, given the pandemic weariness, the factors that you just mentioned, I mentioned, it's important overall to get a very firm grip on the facts around monkeypox and what we need to know. And of course, Henry, you're in a great position to do this. So let's just get down to brass tacks. What exactly is monkeypox?
Great question. I actually was asking myself that. It was a late Friday night during my office hours. Sometimes I just read and read and read, and I really can't stop, kind of go through that waterfall. But what I've been able to collect is that monkeypox is a viral zoonosis, which essentially means it is a virus that can transmit from animals to humans. The symptoms are known to be clinically less severe than the outcomes of smallpox. And I mention that because smallpox and monkeypox are within the same family of orthopox viruses. Its origination has been described to be found endemically within parts of Central and West Africa. But previous to this current spread, I must say we did encounter this in the US before. So, you might have kids. I believe you have kids. So my little warning for you is if you like those furry critters that crawl out and about, you might want to make sure you source it from the US. Basically, what happened was in 2003, there was an infected prairie dog that was imported from Ghana. So I believe the intent was to be a domesticated pet. The overall infection impacted 71 individuals in our Midwestern states. Really, there was no focus on a specific patient population. For example, male having sex with male, bisexual man, which kind of reveals who in general is at risk for this. So the who really doesn't matter. It could really be anyone.
Yeah. And, when I was reading the primer document that you drafted in preparation for this episode, I actually went back and looked at some of the news reports from 2003. And what I saw was interesting. You had put infected prairie dog from Ghana. And that stood out to me just as a general wildlife enthusiast. I was like, oh, I thought prairie dogs were indigenous to North America. So I dug into that a little more. And some of the news reports noted that it was likely from what's called a Gambian rat, which is native to Africa.
Oh.
And apparently the rat spread the infection to the prairie dogs in a suburban Chicago distributor, a pet distributor. That was in one of the reports. Yeah. So I'm not bringing this up to be pedantic or anything like that. Just merely to illustrate the last outbreak when compared to the current one, it was the more the focus was on the zoonotic risks. You could get it if you have a pet prairie dog, which I didn't even know was a thing. People had these pets, and that was putting them at risk. It's just a completely different outbreak then that could be very easily memory holds when compared in context to the current one. Getting back to monkeypox itself in humans, how severe of a disease is this? What are the symptoms we're looking at, and is it is it fatal, or do you have any chronic after effects?
So overall, the severity of disease has been described to be fairly low. You can identify certain patient populations that are deemed high risk, such as immunocompromised, certain metastatic cancer patients, or elderly patients with high risk factors. But currently, a couple of governing health bodies in terms of infectious diseases are communicating that relatively there's really no mortality, and it's fairly safe outcomes with really no long-term side effects that have been described. And currently, definitively, upon an article I read recently, there are no deaths in the U.S. described in the time period of April to June of 2022.
And what about the symptoms, the actual symptoms themselves of monkeypox?
Before I get into that, I just want to make the comment. The symptoms are described actually very well. We've actually grappled with this infection in the past relative to a 2003 symptom that we just described. And the other thing is, in terms of preparation of treatment and recognition and symptoms, we've been developing treatments and vaccinations in terms of strategic defense initiatives relative to weaponization of things like smallpox. And that relationship there is really, because they're both of the orthopox virus family. But back to the point, in terms of the actual symptoms, the symptoms, start with the transmission. That transmission has to occur. And usually those patients that are infected will go through an approximate 7 to 14-day incubation period where they are not contagious. So after this period, they will begin to form kind of like these lesions of the mouth, the tongue, and skin. Other co-presenting symptoms that we've seen that are hallmark is the rash, then also fever, malaise, headache, and weakness. And a really good key feature to tie in with it is relative to the physical examination when our providers do their workup is to just assess for lymphadenopathy. That co-presenting physical symptom can kind of start to rule out some of the other rashes and infectious rashes that do not present with that. So
and what exactly
the symptoms in a nutshell.
Okay. And can you go ahead and explain what lymphadenopathy is?
Yeah, lymphadenopathy is basically whether it's from an infectious cause or an idiopathic, or really there's no reason, or viral cause, your lymph nodes around your body, whether it be under your under your jaw or under your armpits, they basically will swell in conjunction with monkeypox virus infection.
And generally speaking, monkeypox, it usually clears up in 2 to 4 weeks with no real medical intervention necessary in most cases. Is that right?
That is true. I do believe that it has extended past that point for some. Usually that might be for the people that are a little more complicated or maybe immunocompromised or suppressed. Yeah.
And you did note that this disease, monkeypox, has a relatively low severity, but there are going to be cases where there are more severe outcomes. What are some of those associated with monkeypox?
Yeah, I would say, I haven't quite seen many presentations of very severe monkeypox, but what I do know in terms of, direct hospitalization or a need to be seen by a higher level of care is whenever the actual rash or the lesions implant themselves in very critical areas, such as very close to the eye, near your genitals, near your anus, and those implantations can cause complications that can cause issues relative to that that anatomical area. But that's pretty much all I've known. Other things such as sepsis, which is kind of like like a really bad systemic infection that patients can have, where they have fevers and low blood pressures and high heart rates. Those types of things that are typical that you would see relative to really any infection that's viral or bacterial that would call for something that would, be a higher level of care. So really, like, in general, I don't see anything that's really serious or really, causing mortality, but rather, if that rash or lesion implants itself in a critical area that's described to be, like such as your eye or your genitals, like I've explained, or if you just basically get very sick with the infection, that type of mentality would cause for higher level of care.
Let's talk about the transmission of monkeypox. How is monkeypox spread and who does it primarily affect?
Yeah, great question. So I do want to clearly state monkeypox is very rare. We, like many healthcare providers and groups, promote awareness and information as a tool rather than fear. So I just want to say again, this is very rare. So, basically I always usually go into a spiel, but when it comes to how is it spread and who does it affect, I do like talking about the numbers. So back in early July, when we first did our monkeypox primer for clinical update, we only saw 112 cases. Currently, as of August 16th, 2022, we saw about 13,000 cases. So that's quite the uptick, but the cases are growing, but not really quite at the rate we've seen with COVID. So monkeypox is spread via close, in-person, or physical contact, including direct contact with monkeypox, rash, sores, or scabs, contact with objects, fabrics, surfaces that have been used by someone with monkeypox, breathing in respiratory droplets or oral fluids from a person with monkeypox. And that can range from a sneeze, mucus, breathing, and even speaking to each other for prolonged amounts of time. In general, that type of airborne transmission would need to be a fairly prolonged face-to-face contact. I don't believe I've seen any numbers described in that yet. But in terms of who it primarily affects, we're looking at the numbers right now, like I just described. 112 in July 2022. Now we're at 13,000 as of 2 days ago. So stating the facts in terms of epidemiology, from what's been put out, who it's been affecting is mostly men at 98.7%. They are typically 35 years of age. 3% of them are white. 26% of them are Black. And 28% of them are Hispanic. So with those individuals, it has been reported that 94% reported sex or intimate contact with men during 3 weeks before their symptom onset. So given the mode of transmissibility, however, really anyone can be infected with monkeypox. It doesn't really matter, what you do in your free time or whatever orientation you have. It really comes down to knowing your risks at the end of the day. Where do you go? Where do you frequent? Are you physically active? Are you in public places? Are you in crowded places? Are you having communal showers? So me personally, I go to the gym every day for nearly 2 hours a day. That's my thing. That's my, that's my escape. So I know my risk factors and know that this is a possibility for me. So that's why I personally integrate efforts such as always wiping the machines before and after use. We all know that that's probably something we should do to be courteous. But it seems more important now. Wearing long sleeve shirts, pants when possible, and wearing a mask. So definitely not ideal for me with all the strange stares, but hey, sometimes you have to do what works for you. So hope that answered your question.
Yeah, definitely. And something to be clear too, monkeypox is not a sexually transmitted infection. You broke down about the percentage reporting sex or intimate contact. This is not an STI. That's something also that needs to be clear.
Yes, it is not, but you can get it from sexual contact. But the foundation of the transmission is really close physical contact, which can be a range of things from a hug, a kiss, or intimacy. So you're absolutely right, Adam.
You made it clear looking at the epidemiology that men who have sex with other men, that's the population that's most affected by monkeypox at this time, because it affects such a specific group of the population. You don't ever want to stigmatize any group, but you also want to be sure that the group that's at risk gets the information, the resources they need to be safe just as much as the broader population does. Ultimately, as you just brought up, viruses don't discriminate. So everybody needs to be aware.
Remember the Diamond Drug Information Center? That group of expert pharmacists who help Diamond customers with their medication questions? Well, I'm here to tell you that they're a thing of the past, but not in a bad way. No. The Drug Info Center has a new name and a new mission. We're proud to introduce the Office of Pharmacy Therapeutics and Integrated Clinical Services, or OPTICS. Instead of offering just drug information, the pharmacists of Optics are moving their services closer to direct patient care. Whether it's through collaborative formulary management, medication therapy management, or individual patient care plans, the Optics team is ready to integrate their clinical pharmacy expertise into the day-to-day operations of medical teams in corrections and long-term care, and they'll continue to offer the same drug information resources they've provided in the past. To get a clearer view of Optics and its mission, go to diamondpharmacy.com/Optics team to learn more. Now back to PodcastRx.
All right, well, switching away from transmission, let's just talk about naming here. And given its name, monkeypox, and this is a strictly curious question from me, what role do monkeys play in transmitting? We already talked about the prairie dogs, the Gambian rat. I had seen an article, or at least a headline, that it said something about people were killing monkeys out of fear that they were going to spread monkeypox. And just because it has the name monkeypox does not mean literal monkeys. And I think it is worth throwing that in this podcast just to clear up why the name exists.
Yeah. It's actually it's a very interesting story as to how they landed on that. But I do want to take a step back. I just want to review orthopox viruses in general. So the genus of Poxviridae and the subfamily of Cortopoxvirinae, they've selected their hosts long ago as vertebrate mammals, which consist of us, cows, horses, camels, monkeys, and more. Monkeypox was able to be infected, in a prairie dog. That caused a small panic in the U.S. in 2003. So we can just assume monkeys have just as much of a role as a prairie dog shipped overseas, or that rat you were talking about. But I do need to say this as a favor for all those monkeys out there being hunted and killed. I mean, some of them are endangered, and it's a shame that they're being killed. But as someone who was born in the year of the monkey, I have to represent their interests too. So to kind of really take it back even more and be a little more serious, monkeypox was first discovered in 1958 in colonies of monkeys kept for research. Even though it's named as monkeypox, the true source of monkeypox and its original host is unknown. But it has been described that potentially an African rodent, and I think this is where we kind of line up eye to eye on this, I just realized. The African rodent and non-human primates may have been originally the source of this virus. So it really could have been just a rat or just any other monkey, really.
Right. When it comes down to it, it's just a shorthand name. We see this virus in these lab monkeys. It's monkeypox.
Yeah. And they're like,
the name stuck.
It's in monkeys. Exactly.
Yeah.
Exactly. But in reference to those orthopox viruses, it could be any really vertebrate mammal that could be infected with this too.
We noted earlier in our discussion that monkeypox usually doesn't require any medical treatment, but there are vaccines and antivirals available to fight against it. What can you tell us about those?
Oh, great question. This is actually one of the biggest points I really hope to get to our health partners. We did a lot of research recently on a complete list of treatment options for monkeypox, and we found that there are 4 treatment options for monkeypox and 2 vaccines for prevention. So the treatment of monkeypox obviously comes with the positive lab test that the Department of Health has graciously offered to facilitate. After that, agents such as tecovirimat or brand TPOXX, vaccinia immune globulin intravenous, cidofovir, brand Vistide, brincidofovir, or CMX001 or Tembexa, those are available. I will say though, TPOXX is the most reliably available oral or IV agent that has clear dosing, instructions for access, and management of drug interactions and other issues. TPOXX, from what I've been able to gather, can aid in viral load reduction purely by inhibiting production of triple-wrapped viruses versus double-wrapped viruses that are known to accelerate the rate of infection and viral load increase. So, inhibiting that triple-wrapped virus that comes out in terms of their life cycle, inhibiting that will help decrease the rate of infection and the viral load within the body. VIGIV, or the one agent I said, vaccinia immune globulin intravenous, that's a commercially available product used to treat complications from vaccinia vaccinations, which result in certain rash-like symptoms. So if you ever got a smallpox vaccine or a vaccinia-based vaccine, if you got the reaction and you started getting the rash, you could give something like that. I will say, though, dosing is not as clear. Access to it, it's a commercial drug, so that may pose some problems financially, logistically, and logistically more since it's an infusion. And we all know how some of these immune globulin products can be in terms of toleration. We then have cidofovir, which is also commercially available for the treatment of cytomegalovirus retinitis. Dosing is not as clear, as well as access to this agent. Lastly, we have brincidofovir, which is used to treat human smallpox disease. Dosing is also not as clear as well for this indication that we're grappling with. And VIGIV, brincidofovir, cidofovir, once again, those are commercially available. The only thing that I will say, just to backtrack, those are commercially available if selected. That could incur a charge on someone or a site. But as they morph into a drug that's being stockpiled, or the Department of Health wants to be able to distribute this drug in a reliable and accessible way, that price tag may or may not be changed. So to move to vaccines, we do have Jynneos and ACAM2000. They are both live viruses, but with very different mechanisms to induce immunity. So Jynneos, which is generally available to the general public, everyone else, it's a live, non-replicating virus, which is administered as a subcutaneous injection 4 weeks apart. The inability for the live virus to replicate allows for the body to manage the infection as appropriate. So ACAM2000, that's a little different. I do believe that's more for our military personnel and those who work within those research labs that have those monkeys and orthopox viruses. It is derived from the vaccinia virus, which is within the same family of orthopox viruses once again. The vaccinia virus itself is a producer of very mild infections and may only cause a rash or fever. So this application for vaccinia virus allows for protection against lethal smallpox infections as well. In general, about efficacy, I'm thinking some of our listeners are wondering, how is this effective? I don't even think that they did this in humans. And you know what? They're absolutely right. This was only done in clinical immunogenicity studies within animals. They believe that from what they've seen in those outcomes, there's about 85% efficacy in preventing. And the CDC is actually extrapolating those findings into the general communication about its efficacy, 85% efficacy in preventing monkeypox. So that's pretty much it. I know I kind of threw the book at you, but that's really treatment in a nutshell.
Yeah. And going back to the antivirals in particular, right now, would these be prescribed for anybody who has, any patient who has monkeypox, or again, is this often just for more immunocompromised or more people with higher risk for more severe versions of the disease?
That's a really good question. And that is actually something we're always trying to push. Where can we place our patients? Where do they fit? Are we treating their disease state, their infectious disease state as a silo? Are we considering other disease states that are going on? Because what you said is a very good question. Who's appropriate for treatment? Well, some patients aren't appropriate for treatment. There are many contraindications to some of these medications, severe renal impairment. There's major drug interactions that can occur. There's a lot of cytochrome P450 drug interactions that can occur. So management of chronic medications may need to be reviewed. There's things such as thrombosis that can occur. So really, stratifying that risk and trying to find that correct patient population is essential. So to your point, there are treatment considerations that have been communicated by the CDC. Their basic recommendation is, quote unquote, prioritize treatment in X or Y or Z patient populations. So for example, you could have severe disease, and that description kind of aligns with hemorrhagic disease when this occurs, confluent lesions, sepsis, encephalitis, or other conditions requiring hospitalization. Then there's another section for, quote unquote, those at high risk of severe disease. So they'll have immunocompromising conditions, which consist of HIV, AIDS, CD4 counts of 100 to 750 relative to AIDS, leukemias, lymphomas, generalized malignancies, the list goes on. You could prioritize your pediatric patients less than 8, pregnant or breastfeeding women, people with fairly extensive skin conditions such as atopic dermatitis, and other people with one or more complications consisting of dehydration, diarrhea, gastroenteritis with severe nausea and vomiting. And lastly, what I mentioned earlier are the aberrant infections, where basically the lesions will implant in the eyes, the mouth, or other anatomic areas we describe, such as the genitals or anus. So really, when our providers are grappling with, I have a very young, healthy guy who's doing pretty well, isn't very sick. Is it worth going through the strategic national stockpile, getting testing, and getting that drug rushed to them? Really, yeah, that question is obviously reserved for the provider, but I will be able to say that, based upon some of the guidance documents we put out, we'll be able to tell you who absolutely needs to be treated. So those treatment considerations that I've described are available in one of the new guidance that we put out.
Right. I did want to bookend that question. That it was interesting that as we were getting ready to record, I was looking at the news, and there was breaking news today that the Biden administration has actually expanded the number of available Jynneos vaccine doses to 1.8 million to states and jurisdictions, and also they're providing 50,000 additional doses of TPOXX to jurisdictions where the outbreak is most severe. So I thought that was really timely development given our discussion today. Yeah,
I will say to that point for the current administration attempting that, it's a great idea, but we need to understand that supply and demand is something that the manufacturers of Jynneos are concerned with. So that's a great idea, great move from this administration. But yeah, definitely something we need to consider, and that's also something we're always thinking about as well. Just access to these types of agents.
And I wanted to conclude our discussion today going back to your work with optics. From your vantage point, how concerned is the correctional health community, that's who you work with primarily, how concerned are they over the spread of monkeypox right now?
As of right now, the overall feeling does not seem to be too concerning from our correctional partners. We may have only received about 2 to 3 calls relative to questions about treatment. Really, the concern has already been expressed amongst us internally, actually. I feel like maybe optics and the Diamond teams are a little more concerned because we're seeing the overall supply chain being a little strained relative to the strategic national stockpile. So yeah, just to answer your question, it doesn't seem, based upon our correctional partners, that they're too concerned. But we do think about them a lot because close spaces, communal areas, and just a lot of variables in these individuals' lives, social lives, that may or may not cause certain risk for infection. But yeah, generally, our extensive conversation and concern, we basically thought we need to do a preemptive solution to this foreseeable uptake in cases and questions. So what we've been doing generally to help is awareness, guidance, and knowledge. Our conversations about monkeypox they're being revisited every week. We're discussing new demographics, new patient populations, and really trying to understand how we can best spread awareness about this current outbreak. The correctional community, whether or not they have concern currently for monkeypox or not, I would just suggest they could remain vigilant. And by being vigilant, they could watch the news, they could sit down and read what they need, or they could just follow some of our updates that we put out or some of the guidances that we put out. But in general, what I do want to say is our optics team, we're juggling many different things. We obviously have a lot more interest in new guidelines that come out, new landmark clinical trials that come out, new drug applications that come out that we try to integrate within how we practice and how we develop formularies. But basically, we also have a very, very keen eye on public health, given the susceptibilities of our patient population. So, with this podcast, with the primer, with the guidelines that we put out, we really want to try to elucidate these confusing points and really try to hope to centralize all of this knowledge in a way where it's digestible. So, I mean, I will describe to you, writing some of these things, I will say that I probably had 20 plus Google Chrome tabs or something open, 3 to 4 page articles each. The CDC has so many different links that, you know, you click one thing, vaccines, and then at the very bottom it says vaccine guidance for healthcare providers, and you click that, and then you start to see who's, you know, susceptible to this and who are immunocompromised. And that's how I found the table about, you know, who calls for prioritized treatment. So there's so many different things, all this knowledge that we as a group centralize. We provide digestible clinical pearls, and we basically try to disseminate the knowledge in a way where everyone is literally on the same page. We genuinely do care about our health partners and everything they're doing for their patients and us as well. They're so busy, you know, they have so many patients to take care of, you know, their notes to be written. What I try to tell them is, hey, you know, relax. If you trust us, let us take over on these things. We'll send it over to you, and you'll always be up to date and on the same page as everyone else. So that's kind of what we're trying to do.
Well, and I will say, Henry, that's exactly why we enjoy having you on this show. Henry So, it's been a pleasure. Thank you for taking the time to chat with us. And please know that you're welcome back anytime.
Oh, man, that's very much appreciated. Thanks, Adam.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.